The presenting partner of this episode of The Kick is Baby Bunting. Save up to 25% off selected products store-wide in their Stocktake sale now.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr Patrick Maloney.
Well, our guest today is Dr Ed O'Mahony, who is a COGU. Now, Pat, what is the acronym for, what does that mean?
Ed's job is a clinical obstetric and gynecological ultrasound specialist.
Yeah, so this is a very much an expert in his field, and he's given up some of his time to come and talk to us about ultrasound in pregnancy and when you might need the specialist help of a COGU.
I'm excited to have our old friend Ed O'Mahony talking to us today about ultrasound. Ed and I go way back. We used to work together, and then he went off and became a clever ultrasound subspecialist. And I think, our kids talk about anyone's professional background as their origin story. And Ed's got a good origin story. He used to do something else. Were you an engineer or something?
I was an engineer in the distant past, yes.
Yeah. And tell me if I've got this story right, but I think you quit engineering because you were sick of sitting in a dingy, airless office with no windows. And then,
That's right.
And then you spent 15 years training to be an ultrasound specialist, and now you sit in a dingy, airless office with no windows. Is that right?
That's absolutely correct. Yeah, you've gotten one there.
I thought I remembered that.
And Ed, you're based in Australia, but where did you do most of your training?
All in Melbourne, essentially. Well, not all in Melbourne, but certainly all in Australia. So I did a medical degree at the University of Melbourne as a postgraduate student. And then I did an internship around Victoria. And then I started training at the Royal Women's Hospital as a junior resident in obstetrics and gynecology. I did that for 6 months. I did another 6 months in the neonatal intensive care unit. And along the way, met some fairly inspiring mentors. And so pursued specialty training in obstetrics and gynecology. And I was predominantly based at the Royal Women's Hospital as my core hospital. And then I met Pat on a year rotation out to Ballarat in my 3rd year of that training. And then I returned to the women's for my 4th year of training. And I had determined at that stage that I wanted to subspecialise in ultrasound. And so I applied and gained a position on subspecialty training in ultrasound. And that was a further 3 years. So that's training that you undertake in high-risk centres where you're pretty much scanning all day, every day. And that's so that you can get exposed to the variety of conditions that come up in obstetrics and gynecology that you wouldn't necessarily get exposure to in a low-risk centre, and also to gain experience in invasive ultrasound procedures.
Yeah.
So be that diagnostic testing in pregnancy for various genetic conditions or infections, and also in gynecology, invasive ultrasound procedures checking the patency of the fallopian tubes, and also advanced scanning in deep infiltrating endometriosis, so that the patient and surgeon have as much information as can possibly be determined on ultrasound ahead of a planned operation.
Yeah, perfect. We'll get onto that in more detail a bit later on. But just to clarify for our listeners, someone who does Ed's job in Australia as a COGU is a fully trained obstetrician and gynecologist before they go into the ultrasound field almost exclusively, which gives them a special insight into what your obstetrician might be looking for if you go to Ed for a scan. And because Ed, in Australia, somebody who has been referred I might refer a patient for a pregnancy scan, and that scan might actually be done by a general radiologist or their sonographer, or they might be done in special circumstances by someone like yourself. What's the difference between you and, say, a radiologist who might also do pregnancy ultrasound?
So the difference between a COGU and a radiologist is how we've come to the job and our background, essentially. So as a COGU, because we're trained initially as obstetrician gynecologists, we have done the operations. So we know, for example, if a woman has a fibroid, we know what is and is not feasible in terms of how you would make a surgical approach as to remove that, or whether it should be removed at all. And equally in pregnancy, we have insight into if we identify a particular abnormality, is that something that is significant or not, and how is the pregnancy best managed going forwards. So we're in a unique position to be able to counsel patients on the spot if an issue comes up, and we can be the line of last resort in many cases as to what's the significance of something that's been identified on scan. Radiologists have a completely different training pathway, so they're trained, they're medical doctors also, specialist medical doctors, and trained in imaging. There's a lot they do that we can't do, so they're trained in CT, they can trained in MRI, but their training in obstetrics and gynecology might actually make up a very small part of their training on their way through. So when it comes to obstetrics and gynecology, COGUs would certainly, we know a lot more about a smaller area, whereas radiologists would know more about a broader area, covering wider aspects of imaging, but then they would tend to refer to us for second or third opinion if they found something of concern during an obstetric or gynecology imaging investigation.
Ed, can we start with what time in a pregnancy would somebody expect to have a routine ultrasound? And then we'll go on and talk about when they might come and see you as a COGU. So
one of the first things that's important in determining the pregnancy is actually how far along it is, and setting that baseline of accurately dating the pregnancy. And that is done very well from as soon as the embryo itself is visible. We call the baby an embryo until it gets to about 12 weeks, and then after that it becomes a fetus in scientific terms. There is some debate in early charts, but they're pretty consistent from around 8 weeks. So 8 weeks is a pretty good time for a dating scan. But we will see women earlier if they're at risk of certain conditions, for example, an ectopic pregnancy where the pregnancy is implanted outside the uterus. That's a condition, if a woman who has a history or risk factor for that, we'd rather see her sooner to exclude that condition. So we could see her from around, late 5 to early 6 weeks. It's also, it can be a bit of a gap. Then the first time we can really make a good assessment of the anatomy of the baby reliably. I find that that's often best done at around 13 weeks. And it can be quite a gap between dating a pregnancy on ultrasound at 6 weeks to a review again at 13 weeks. And while the chance of miscarriage is very low if you have a live baby at 13 weeks, there is a reasonable chance of miscarriage between 6 weeks and 13. So if someone is considering having screening for Down syndrome, trisomy 13, trisomy 18, before 13 weeks, if they're having that done around 10 to 11 weeks, it may be worth a little check, just making sure that there's still a heartbeat there at the time that blood test is done, so that if the pregnancy has actually miscarried, that they're already aware of that before further testing is embarked on.
Tell us more about that 13-week scan. The baby's still pretty small at that stage. What can you really see on a 13-week scan?
We can see an incredible amount at 13 weeks. So we get, with good equipment and in the right hands, we can really do a top-to-toe examination of the baby. So we can see that the skull shape is normal. We can see that the brain is developing nicely into two separate halves. We can check that the baby has a normal-looking profile. We can exclude some very major heart abnormalities. We have to bear in mind, though, the heart is the size of 2 grains of rice at that stage of pregnancy.
Wow.
We do need to look. So we do need to look again at the heart later on, ideally around about 21 weeks, to be more confident on excluding some more subtle heart abnormalities. We can check that the baby has all its fingers and thumbs. At that stage of 13 weeks, we can check it's got 2 legs and 2 feet. We can check that it has a bladder, that the stomach's on the right side of the body, that the spine looks normal. And we can check for several major abnormalities in those organ systems. So about 2/3 of the abnormalities that we would expect to be able to see at 21 weeks, we can identify at 13 weeks.
That's amazing.
I
And
didn't know that.
Yeah.
That's impressive. Yeah.
And so would you be seeing anybody as a COGU at that first 0 to 13 weeks, or is that generally more routine?
No, look, we absolutely can. I mean, COGUs will see women routinely as well. The challenge is about access, really. There are approximately 8,000 sonographers in Australia, and there are about 50 COGUs in Australia. So it's a big difference, and COGUs tend to be located around the big cities. There are exceptions, but most tend to be located around the big cities, so it's not always possible to get access to them. So it's if they're available, you can see them, but equally, sometimes it's done by referral for a second opinion when concern is found on something on a general scan.
So, Ed, in the first trimester, what would some of those secondary referrals be to a COGU?
Sure. Well, just I guess to back it up a little bit, sometimes it's even on the dating scan. So at 6 weeks, we can actually identify the number of pregnancies. So if we're looking at a twin or a triplet or more pregnancy, so we may get called on at that stage to identify what particular type of twin or triplet pregnancy is this, and to counsel appropriately as to look, where is this pregnancy best managed, and what is an appropriate obstetric management plan going forwards for pregnancy like that. And also the machines just keep getting better and better, and we're seeing more and more, and so we'll often get questions from second opinion if someone's seen something abnormal on a scan. It may be that as part of assessing an early pregnancy, that there might be a suspected abnormality on the baby on very early views that we're asked to review, and it's not always bad news. Sometimes there is as the embryo develops, there are some structures that start out in areas that those who maybe haven't done as many scans wouldn't be familiar with. For example, our abdominal wall has a herniation through it very early, which we expect then will return to the abdomen by about 11 weeks. And sometimes a finding like that might cause concern very early, and we can reassure in that setting, and then sometimes it turns out that it is a genuine problem. It's also important to know at this stage of the pregnancy that everything's very small, and it's very deep inside the woman's body, so we often have to perform a safe transvaginal ultrasound to actually get clear images. And sometimes at that stage we can identify incidentally that we may find a cyst on the mother's ovary that is of concern, and that's something that might sometimes get sent in for a second opinion as well, just to see is this just a normal pregnancy-related ovarian cyst, or is it something that requires further managing, further monitoring, or even removal in pregnancy.
Yeah.
That would be fairly rare, I would have to say.
How that child travels later on.
Parents, listen up, because right now there's a mega sale happening at Baby Bunting, and your wallet will thank you for these incredible savings. You can save 15 to 20% on selected Britax Plus series car seats, ensuring your little one travels in style. Or check out the massive savings of up to $300 off selected Maxi Cozy and InfoSecure car seats. That's right, up to $300 off. And the savings continue right across the store with up to 25% off selected car seats, feeding products, Manchester prams, cots, and more. Everything you need for your growing family at prices that won't break the bank. Baby Bunting's huge Stalk Take sale is on now. Save up to 25% off selected products store-wide. T's and C's apply. Sale ends Sunday 29th of June, 11:59pm AEST.
Ed, I'd be remiss for our audience if I didn't ask you, are there any issues with regularly using ultrasound to scan a baby, to either the baby or the mother?
So, to the best of our knowledge, there is not, but we always operate on the principle which is known as ALARA, so that's as low as reasonably achievable. So we use as little ultrasound as possible so that we get the important diagnostic information that we need, but also that we don't expose the baby to more ultrasound than is necessary. So, for example, we'll try to avoid using some of the higher intensity modes of the ultrasound, particularly before 10 to 11 weeks when the baby is very small. And it's not that harm has been proven, it's more that if a study comes out years down the track that shows that ultrasound wasn't quite as safe as we've always thought to date, then we know that we've always kept it to a minimum in the interest of the mother and the baby.
And that gets harder if the pregnancy is high risk, because sometimes there's weekly monitoring, isn't there? Does that cause undue stress for that parent?
Look, there's no doubt it can be very stressful, a pregnancy that requires a lot of monitoring, but we don't feel that, no studies have backed up that the ultrasound waves themselves have caused any harm to mother or baby. And it's something that has been extensively studied over 40 to 50 years, and with no harm found at this stage. I think it's pretty unlikely.
Good. And tell us a little bit about these procedures that might be referred to you in early pregnancy. Are people still coming for chorionic villus sample amniocentesis?
So, yes. So there are a number of different indications where chorionic villus sampling is needed. So essentially what chorionic villus sampling is a biopsy of the placenta, and ideally that's done somewhere between 11 and late 13 weeks. A lot of chorionic villus sampling was done when we had less sensitive and specific tests available to us for screening for Down syndrome as a condition.
Sure.
So these days, because the cell-free DNA screening, or NIPT, NIPS, non-invasive prenatal screening, non-invasive prenatal testing, that has far superior performance as a test to the combined first trimester screen. So that has detection rates in excess of 99% for those conditions that it screens for. And they're quite common in terms of genetic abnormality. They're quite common conditions. So that's very powerful testing. So we're finding we need to do fewer and fewer chorionic villus sampling tests for those specific conditions. However, it's important to know that those conditions really are just looking at the top sort of 4 to 5 genetic abnormalities, and that while other conditions are rarer, there are a lot more of them. There's a lot more can go wrong in the other chromosomes. So regardless of the NIPT being low risk or a low chance of abnormality, then if we see a baby that looks to have structural abnormalities, we would still offer an invasive procedure to look at the other chromosomes that would not have been examined by an NIPT test.
Yeah.
And similarly, The NIPT tests are, they're great tests. They're a huge leap forward, but they're not perfect. And so if they identify that babies at increased chance of being affected with Down syndrome or trisomy 13 or trisomy 18, we know it's important to actually confirm whether that is a true result. We would strongly recommend performing a chorionic villus sample to confirm that it is indeed the case.
Yeah, and you do that, Ed, that somebody then would be referred to you?
Yeah.
Yeah. So what would somebody expect coming to a COGU office if they needed to have any of that CVS done?
So we'd have a discussion about the tests that they've had up until that point. We'd have a look at the baby on ultrasound and see were there any obvious structural abnormalities that gave further insight into whether the blood test was likely to be right or wrong. We'd have a very open discussion with them about that the procedure is generally safe, but it's still not a risk-free procedure, and that there's a chance of pregnancy loss as a result of having the procedure. Even in the very best, most highly trained hands, it's not risk-free. It's still an invasive procedure. We would perform it as a sterile procedure, so it would involve cleaning mum's skin, administering a local anaesthetic, and passing a needle under ultrasound guidance targeted needle into the placenta itself, taking a tiny biopsy, and then removing the needle and checking baby's heartbeat afterwards, and also giving some anti-D in the event that a mother had a rhesus negative blood group to protect her against forming antibodies against a future pregnancy. We'd expect a bit of cramping that night, maybe a spot or two of blood, spot or two of liquid. That's not terribly unusual, but it's generally a fairly well-tolerated procedure.
Ed, what are the circumstances in which you might be performing somebody's otherwise routine second trimester anatomy scan?
So I will see patients routinely. Most other COGUs that I know of will sort of blend. They will do some public work where they may be a consultant in an imaging department in a large metropolitan hospital. And then they may also do some private work where they either will see patients, some use sonographers to perform the scans, others will scan themselves directly. So I would do a mixture. When I'm scanning, I would be seeing a mixture of women who were in so-called low-risk pregnancies and also women who were referred in for second opinion after a concerning finding elsewhere.
Sure. And of those concerning findings elsewhere, what sort of things are we talking about for second trimester scanning?
So it can be a huge variety. It's important to know, I guess, that there are some misconceptions creeping out there. So one trend is that, if I've had a blood test at 10 weeks that says the baby isn't affected with Down syndrome, trisomy 13, trisomy 18, that everything's okay, and I just have a 20-week scan. And then sometimes we are finding things at 20 weeks that could actually be detected an awful lot earlier if we'd had a look at 12 or 13. And so if you go, again, top to toe, you can have conditions such as acrania, where the skull hasn't formed. That's a lethal condition and not survivable. And that's absolutely detectable at 12 to 13 weeks. So that's a real tragedy, I think, when we're seeing that for the first time at 21 weeks.
So just to clarify, somebody could have had an NIPS test that was normal, no other early ultrasounds, and then turn up for a 20-week scan and find something that bad.
And in fact, that's sometimes in some public systems, that is the protocol, that the 12 or the 13-week scan isn't part of the routine care that people receive, and they have to either privately pay for that. Is that your experience too, Ed?
That is correct, yes. Yeah, the public hospitals are not funded to perform 12 to 13-week scans and indeed 20 to 21-week scans on all the patients that will ultimately deliver with them.
Wow.
But the resources just aren't there.
And I find that just incredible that funding isn't there for those two scans.
I mean, there is funding, there's Medicare, but it's just the hospital that you ultimately deliver at may not have, is likely to not have an imaging department large enough to see you for your scan if you're low risk, and so those scans would need to be done in the community.
Yeah. All right.
Do you keep dating the wrong people?
Are you a chronic people pleaser?
Maybe you want to know how to spot the narcissists in your life and what to do about them.
I'm clinical psychologist Dr Anastasia Horonis.
And I'm Ashani Dante, and we are your hosts for But Are You Happy?
Bringing you all the self-development and mental health information you actually need.
But Are You Happy drops every Saturday morning.
Just in time for your hot girl walk.
Tune in because self-development is more than a matcha and a mantra. Brought to you by Medibank.
Okay. Let's move on to the scanning that you do in the third trimester. We've had some interest in this in the last few weeks because of this, the big baby trial, and I think it's brought to everybody's mind not only how we should be most appropriately managing babies that seem too big in the third trimester, but just how good are we at this? How good are you at telling me how big my patient's baby is going to be if I've sent them for a growth scan at 35 weeks, because with my trusty old tape measure, the belly seems too big? Yeah.
So, I mean, we broadly say with ultrasound it's plus or minus 15%.
That's a lot, isn't it?
That's a lot. So 15% of 3 kilos is going to be plus or minus 450 grams. So that's 900 grams from smallest to largest. So it's quite a variation, you know.
Yeah. So what can we...
As the pregnancy advances, it actually gets more and more difficult to get those measurements as well. So a lot of it is the abdominal circumference, and so that's going to be very dependent on, or more dependent than we'd like anyway, then it's more dependent on how a baby's lying or what part of the breathing cycle it's in. And so we take a few measurements on a growth scan to try and reduce that error, but try to stay humble. We try to acknowledge that it's plus or minus 15%, and
Does it help to take multiple scans?
Look, you can look at growth velocity. So growth scans at different growth scans at different gestations. Again, it comes down to a resourcing issue. Like, the resources just aren't there to scan everyone 2 to 3 times in the third trimester. So a lot of the time it becomes a triage process of who's most likely to have a very small baby or a very big baby based on risk factors and based on measurements, tape measurements in clinic.
Tell us more about the small baby. Apart from the overall size of the baby, what else are you looking for on those scans to try and report back to me about the well-being of that baby?
So we're trying to differentiate between babies that are small and well and small and unwell. So if you're a baby that's small just because your parents are smaller or it's a small family, then it's far more likely that you're fine. And then we also check blood flow in the placenta and on a few different blood vessels in the baby to get an indication of, are we seeing signs of resistance in the placenta? Also looking at the baby from top to toe to see, does it look structurally normal? Because sometimes babies are small, they're small because the placenta is not working well, and that can show up in patterns of the blood flow. If you've got a placenta that's not working well because its blood vessels aren't as compliant as they should be, or the placenta hasn't bedded in as well as it should be, we can get clues by, we call it Doppler, where we're interrogating the blood vessels and looking at the patterns and flows, and we've recognizable patterns that show us that a placenta isn't functioning well. Also, if you've a baby that's very small with parents that are larger than average, that would be a bit of a concerning finding. We're more worried about those babies, and that there's something going on that is of more concern than just a baby that's a little small and well. So things we would look for in that setting would be any structural abnormality that would give us the clue that there might actually be an underlying genetic problem with this particular baby, or it may have had an infection, been exposed to an infection in the womb. So we look for signs of that as well. So it's really, just a really comprehensive top-to-toe examination, and looking at not only size but well-being and the structures to get a clue as to can we be reassuring that there's a small bowel baby, or do we need to escalate this? Is this a baby that needs to be delivered early, or is this a baby that we need to offer further testing on to see what exactly is going on and why it's small when we don't expect it to be small?
Ed, in that Big Babies trial, it wasn't, I can't get my maths to sort of add up, but 15% either plus or minus. But they were recruiting people where they suspected the baby would be in the 90th centile, but only 60% of those babies ended up being over the 90th centile. Like, what can we do other than do growth scans at that stage to determine whether you've got a big baby on board?
Ed's doing his best with the ultrasound.
I have to say, first of all, I haven't read that trial yet.
It's not very, I think that
it's got us nowhere.
It really has got us nowhere.
Yeah.
And what it's done, there's the incidental finding will come out about ultrasounds and growth scans. So the internet's gone basically about how ineffective growth scans are.
Well, that it might be wrong. But of course it might be right.
Yeah.
Yeah. Ed, you mentioned at the start of our discussion about some of the gynecological referrals that you receive. Now we're talking mostly about obstetrics here, but our listeners are interested in fertility. And you mentioned a test that you do to look at tubal patency. I do a lot of tubal patency testing myself at laparoscopy. And at laparoscopy, I'm squirting some blue dye up the vagina, through the cervix, through the uterus, down the tubes, and I can see it shooting at the end of the tubes at my through my laparoscope. How do you do it, and how is it done in your clinic in a way less sort of invasive way?
Yeah. So I would say, first of all, that we would defer to what you do at laparoscopy as being the gold standard.
Oh, sure. But not everyone needs a laparoscopy just to have this test, right?
That's right. But then, you have the risk of surgery to get that answer. So to assess the patency of the fallopian tubes, we would perform a particular type of gynecological ultrasound. So the first thing to say is that the woman who's having that scan done, the worst thing we can do is, like, generally it's being done for fertility and assessment of fertility. So the first thing we have to make sure is that we couldn't possibly be doing it at a time when a woman is pregnant. So we'll book that in to be done just after a period has finished. And then we'd perform a sort of a 3-part scan, a brief screening ultrasound over the woman's abdomen, where we're making sure there's no big cysts on an ovary and no huge fibroids in the uterus that may not be visible with the internal scan. But ultimately, it needs to be an internal vaginal ultrasound. We then perform an internal vaginal ultrasound where we examine the uterus and the ovaries and just see, is there any reason, any obvious structural reason why this woman may not have been getting pregnant so far, or any gynecological issue that may impact pregnancy. And once we've finished that, we proceed on to the tubal patency test. So what's involved in that is we use the speculum device, which is the same device that's used for the pap smear, clean the woman's skin, so clean the vulva, pass the speculum in, clean the cervix with an antiseptic, and then pass a very, very narrow tube or catheter in through the cervix, the neck of the womb, and inflate a tiny little balloon the size of like a garden pea. So that's just to hold the tube in. Then we'd inject a little bit of foam. And what we're hoping to see is that foam is visible on ultrasound. We're hoping to follow that foam out through the tubes and see it bathe the ovaries.
Okay, so you can follow it all the way down.
Yeah. it's a valuable test. It can provide useful information if it gives a clear answer, and 90 to 95% of the time it'll perform similarly. It gives a similar answer to the tubal patency test at laparoscopy, and it avoids a laparoscopy. But look, ultimately, it's not for everyone. It's not a pleasant test. We expect some pain. We expect a bit of bleeding, and as with any time that pass a medical instrument into the uterus, even with the best of care and sterile technique, there is a small chance of infection to the order of about 1 to 2%.
Yeah.
Okay.
Well, Ed, I'm thinking that somebody listening to this will have a really good understanding if they've ever been either referred onto a COGU or are lucky enough to have a COGU during their pregnancy as their person, their guy to go to. What is it that excites you about your field, and is there any new research that you want to share with us?
There's a lot to get excited about, both in obstetrics and gynecology. In my obstetric role as an obstetrician in the fetal medicine unit at the Royal Women's, we'll see women and families who are referred in for abnormal findings on investigations during pregnancy. It's obviously a dreadful time. It's a clinic that no one really wants to end up having to go to, but I think it's a very valuable resource, and it's amazing over the years just seeing the answers we're getting now by advanced genetic testing. You might find 2 or 3 unusual structural abnormalities maybe identified in the same baby. You know that when there's more than one structural abnormality in a baby in different systems, it's quite likely there's something genetic underlying that. And we're now getting, with targeted genetic testing, we're finding genetic syndromes that may previously have taken 12 to 13 years of going to specialist clinics in a children's hospital before someone can really put their finger on a diagnosis, to now being able to identify that same condition and give parents an answer during pregnancy. So that is, for me, it's incredible. And there isn't a month goes by that you don't see an answer like that for couples. So that's extremely rewarding to see that. On a gynecology front, we're seeing just the scanning improving, the education improving, the resources that are available to us in ultrasound, the great research and education that's being done to really open our eyes as to what's going on with various conditions. And the one that I found really rewarding in recent years is deep endometriosis, and just trying to make sure that the gynecologist and the woman going in for treatment have the best idea of what we're likely to find. We know that we can't see all endometriosis. We know a lot of superficial forms of endometriosis will give us little to no clue on ultrasound, and I think that's probably likely to remain the case. But where we can be very helpful is assessing the extent that the bowel is involved in deep endometriosis, so that if the gynecologist is planning a surgery for a patient, that they know, okay, I think I'll need a bowel surgeon in the room with me for this, so that we can do it all at once in one operation for you, rather than having to do the gynecology part of the operation and then booking a colorectal part of an operation down the track. It's very rewarding seeing someone who maybe has had 4 or 5 scans over the last 20 years and being the first person to tell them that actually the reason they've had those really, really painful, miserable periods for years is the deep endometriosis that we can see on the scan with good training that hasn't been seen before. And there are often tears in the room and a mixture of validation and sometimes relief, sometimes upset that it has taken that long to reach a diagnosis. It's good to see things move forward and improve. I guess the shame is that it's not available to absolutely everyone, and it does take thousands and thousands of times doing it, hours of experience to actually be able to recognise those pathologies so that you can identify them.
Yeah. Ed, we're really grateful that you could come on and share your expertise and give our listeners a real understanding of where your expertise and training fits into the care of our patients. So thank you so much.
Thank you, Ed. Thanks for coming.
Cheers. Bye.
Well, that's it for us this week, everyone. We hope that you really enjoyed that episode. As usual, if you love it, then just pop into our Instagram DMs and tell us what you thought of the episode. We would love to get your feedback. And we're here next week in your ears.
Thanks for listening, everybody.
Bye for now. Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby. With your own healthcare provider for your individual medical advice when you grow your baby.
The presenting partner of this episode of The Kick was Baby Bunting. Save up to 25% off selected products store-wide in their Stalk Take sale now.